Okay, should we begin? Perhaps since we're running on a very tight schedule today, unfortunately. So welcome everyone. I'm Sharon, and it is my pleasure today to be chairing this meeting. And today we have 4 candidates who will be presenting their presentations, which they have submitted for the best abstract session. Each presentation will be 10 minutes long, and at the end of each presentation, we will have some time for a brief question and answer session. And audiences can score the abstracts with the links given. I'm sure that Gary has sent them out to you all. And it will be scored out of 10, and we will then average the scores, and the candidate with the highest score will win the session. And we will be announcing the details or who received the award at the closing remarks, and I'll also send an email out to notify all candidates. Okay, so since Monica and Muammer is not here today, can we have Josip, Andelo, Borovac to present first?
Yes, I'm here. I hope everybody can hear me.
Yes, we can hear you.
Thank you. So, sorry, am I going first with the presentation?
Yes, because the 2 presenters before you
are not
unable to present.
Yep.
Thank you.
Okay, let me just Does everybody see my screen?
Yeah.
Yes.
It'd be nice if you can make it full
I'm
screen,
gonna...
actually, Joseph.
Yep, I will.
Right.
Okay, I'm trying. Let's see how it goes.
It's gone totally black, actually. It's coming.
Do you see it now?
Yes.
So you see the full screen?
Yes.
Excellent, thank you. So hello everybody. My name is Josip. It's a pleasure to present at this conference. What I'm going to be presenting is the Wellens syndrome, the title of this presentation, and the question: is it the last remnant of unstable angina in the high sensitivity cardiac troponin era, as we all know it? I work in Split in Croatia, which is a large university hospital on the coast, and we have a lot of different cardiology cases, many patients and high volume centers, so we see actually this quite a bit. But it's always good to remind ourselves and especially colleagues working in emergency medicine that there are many presentations of high risk acute coronary syndrome that might not always be ST elevation, myocardial infarction, or something that is more recognizable in daily practice. So does the unstable angina exist in the era of high sensitivity troponin assays? It's actually a very interesting question. We all know that nowadays the assays are very sensitive, also very specific, and pick up very small amounts of troponin which is circulating, and many of these presentations, of course, might represent myocardial injury due to other causes than acute coronary syndrome. So there were many papers and many research publications that were dealing with this question. Is there a space and is there unstable angina present in today's continuum in modern cardiology and emergency medicine, because we have these very sensitive assays? So it's always an interesting question, in my opinion, to look at. So I'm going to be presenting a case which was a 16-year-old woman. She had rheumatic fever in childhood, breast cancer in 2010. She did surgery, chemotherapy. She is in remission, has regular yearly controls that are showing that her disease is under control. She has arterial hypertension, and she was diagnosed quite recently before the current index hospitalization. She had paroxysm of atrial fibrillation 7 years ago, prior to current presentation, and she converted spontaneously to sinus rhythm. She has a positive family history for premature coronary artery disease. She was not a smoker, does not consume alcohol. She was on current medications, aspirin, perindopril, indapamide, and vitamin D supplements. It was quite unclear why was she on aspirin, but that's what she told us at initial hospitalization. She was taking it at that time once daily. So during the exam in family medicine, she was not in chest pain and she was afebrile, nothing extraordinary in the physical exam. Her LDL cholesterol was 4.3 millimoles per liter, and the ECG she took in the primary care office, which was during the yearly checkup for a job, showed some abnormalities to a primary care physician. A primary care physician also did, based on this ECG, initial ambulatory point of care troponin test that was turned negative. She was instructed to go to ED. I mean, she was not in a chest pain. She was clinically stable, and she was sent basically to the ER from her from her primary care physician. So this is the ECG that was recorded at the primary care physician's office. This was, as we all know, Wellens type A biphasic waves in anterior leads. She was not in any chest pain. She had no complaints whatsoever. She did complain to primary care physician that she experienced intermittent episodes of chest pain in the last couple of months. I think she also had COVID infection a couple of months prior to this presentation, and since then she was saying that, you know, sometimes she has anginal symptoms that would spontaneously it would be gone spontaneously. Okay, so she has no chest pain, does not complain on anything. We have this ECG that was recorded. Several hours later, this lady arrives to the emergency department. We do the ECG in the ED department, and this is what the ECG shows now. Now we have Wellens type B, obviously evolution and progression for Wellens type A to type B electrocardiographic manifestation showing deep inverted T waves in anterior leads, quite symmetrical, with preserved R wave precordial progression. She is still without chest pain, has no complaints, but now we have dynamic evolving changes on ECG. We know what to do, we know what this is. So the ED physician notes that this is sinus rhythm at average frequency of 73 beats per minute with negative deep symmetrical T waves in the anterolateral region, suggesting Wellens reperfusion pattern of myocardial ischemia. We did the labs, and now the high sensitivity cardiac troponin T, which is a real hospital assay, now returns of being mildly elevated. So the coronary care unit was activated. Patients were transferred upstairs with goal of performing coronary angiography. She was loaded with 300 milligrams of aspirin. We also give subcutaneously, we give low molecular heparin. And then we did the urgent coronary angiography. She was loaded with ticagrelor on the table. We gave 5,000 units of heparin. And coronary angiography showed the subtotal 99% occlusion with intermittent pattern of full occlusion in the proximal LAD with 30% osteostenosis. We also find borderline focal stenosis of about 50% in mid-circumflex artery, which had tortuous anatomy. Right coronary was dominant without obstructive coronary disease. So what we did was we implanted a stent in a proximal LAD. And the lesion in CX, we didn't find it as significant. At this point, we decided to treat the rest of the coronary disease with medications. So this was the critical proximal LAD stenosis. We see the clearly unstable plaque in the proximal LAD. We performed prompt reperfusion with the TIMIT reflow that was established after stent implantation. So procedure and post-procedural course were uneventful, and her systolic function was preserved. So basically, we prevented a true MI and prevented a large myocardial damage. This is most important vessel. And she also performed stress treadmill tests 2 months after this presentation, after stenting, and she had normal stress tests without signs of inducible ischemia during submaximal exercise. So the patient does well, has no anginal complaints in her daily activities. So this case is I took it in order for us to have sort of a recapitulation and always keep in mind these atypical, I wouldn't say even atypical, but patterns of myocardial injury and acute coronary syndrome that might not be evident to a large-scale pool of physicians working with these patients. So in Wellens syndrome, we all know, which was described first in 1982 by Deswan and Wellens, it is a clinical syndrome that shows the T-wave repolarization ECG changes that are associated with critical proximal LAD occlusion. And it's important that this is recorded during the pain-free interval, because at that time, vessel is still patent, it's still not fully occluded. Cardioselective enzymes can be normal or only mildly borderline elevated, which was the case in this presentation. So she had negative initial troponin, point of care troponin test, and the second one in hospital was mildly elevated. No precordial Q wave should be present per definition. There could be isoelectrical ST segment or less than 1 millimeter of ST segment elevation is allowed, and there is preserved precordial RA progression, which is what we had here. Two patterns are recognized, type A and type B. We already discussed that, and T-waves can change. They can evolve from type A to type B pattern, which tells us there is about the importance of serial and sequential ECG recording. There could also be pseudo-normalization of the precordial T-waves, which is usually a sign of ongoing reocclusion of the LAD. So that would not be a good sign that we have a classical cascade towards anterior stemi. And a little bit on epidemiology. It's, in a large urban non-selected population, it was shown that the prevalence is about 0.1%. Of course, in selected patients, such as ACA patients undergoing PCI, could be about 5.7%. In non-STEMI patients undergoing angio, which is an analysis by Kobayashi and his colleagues, was 8.8%. And in unstable angina patients, this is derived from original papers, Wellens syndrome is present even up to 18% of cases. So this is also a moment to give a large tribute to and recognition to Hein Wellens, which was a first person and a very renowned electrophysiologist who described this phenomenon. So the take-home messages will be that this case report exemplifies all of the aspects of evolutionary ECG changes that are associated with proximal LAD occlusion. There was a transition from type P to type B Wellens pattern present. At all times, patient was in chest pain-free state. In the era of high sensitivity troponin, Wellens syndrome might be the last form of true unstable angina. Prompt recognition of this ECG pattern allowed for the urgent coronary intervention to take place before the full-blown anterior STEMI occurred. Patient had uneventful recovery without developing MI, discharged with normal left ventricular function with unremarkable peak troponin values after PCI. It is crucial that ED physicians and non-cardiology specialists are able to recognize this pattern, since it is associated with poor outcomes if left untreated. And I also think that this should be regarded as STEMI equivalent, despite not meeting traditional ST segment elevation criteria. So this is also a decision tree scheme that you might look later on when you review this presentation. I think it was quite nice. And please support OMI paradigm, which I also saw in this Congress. I was very pleased to see that there were lecturers giving talk on this approach towards ECG presentations in patients with ACS. So I would really advise and I would congratulate our colleagues that are working hard on getting this paradigm recognized and more established in clinical practice. I thank you all for your kind attention. Thank you.
Thank you, Joseph, for your great presentation. I'd like to ask if there's anyone on the floor that would like to ask questions. You can just ask directly or raise hand.
Maybe I can start. Hi, Joseph. Thank you so much for your excellent presentation. Very interesting case. So we definitely should push the STEMI equivalent paradigm because, as you know, the STEMI criteria isn't actually that sensitive, and we're potentially missing out a lot of cases that are urgent. So I'm just wondering, from your previous experience, how urgent is this type of Wellens case compared to, say, patients with the winter pattern? Would you place a higher level of urgency for the latter?
Right, that's actually the good question, and yeah, it's not so easy to answer that one because we all work in different systems. We all know that management of non-ST elevation acute coronary syndromes is very heterogeneous in many countries, depends on your pathways and system that you're working on. So basically, I think the Wellens pattern should be done urgently. So the urgent coronary angiography as soon as possible. It's not always feasible. We have some real-time issues. Like, for example, in my hospital, somebody has a Wellens on a Friday night or in the middle of a night, cath lab might not be activated during that night. So the patient would be given, for example, as in this case, one antiplatelet agent. We will go to low molecular weight heparin. We will do monitoring of this patient. He will be put on a monitor. And obviously, if he's not in a protracted chest pain or he doesn't have any symptoms whatsoever, such as in this lady, we might buy ourselves a couple of hours and do the angiography early in the morning, for example, if of course, nothing happens in the meanwhile. So the patient starts having chest pain or any other symptoms showing us that there might be a reocclusion going on. So basically, we do strict monitoring these patients. We do give some anti-thrombotic management. And of course, we do the PCI and coronary angiography as soon as possible. So if it's during the day, let's say patient comes with Wellens 12 o'clock p.m., like we will do angio, within like 2 hours or something like that. So we have good experience with this because we always, depending on timing, not always the same pathway, but we always prevent MI. And these patients have, very low peak troponin values after the intervention, and they do well. They do well, but it's a good question is how we should proceed in terms of like structured way towards a Wellens pattern, because it is an LAD occlusion that's in its formation. So I think it should be given an absolute priority, and depending on the system, if you can do it right away, it would be the best solution to do invasive workup as soon as possible.
Thank you.
Welcome.
Can we have Hai Ping? You have your question.
Hello, Joseph. Thank you for your presentation.
Hello.
So
thank you.
I have a question about ECG features of this syndrome, Wellens syndrome, because I
Yes.
did a brief research on Google Scholar. There's very limited literature on this. Most of them are from the clinical observation. So is there any algorithms for the automatic diagnosis of this syndrome? Thank you.
Can you please repeat the question? I didn't quite understand the last part, please.
Yeah, because in your slides, I saw you showed some ECG features for this syndrome. So is there any automatic algorithms based on, for example, machine learning on the diagnosis of it?
Okay, I see. So I'm not at this point aware that there are machine learning applied to the recognition of Wellens syndrome. Usually, like ECG machines, as far as I know, would say these would be some repolarization abnormalities, and in this case, obviously, it's a very serious repolarization abnormality that we solve with stenting. So, so we should definitely. I think the future will be to feed AI and artificial intelligence systems with many of these ECGs to make them learn that this is the pattern of serious anterior ischemia, and that this should be classified as an MI, should be classified as an urgent ACS situation. So I'm not aware about the scientific works or projects that are ongoing with respect to machine learning of this pattern, but I think in the future that is likely the way to go, because these algorithms are getting better and better as we speak. So I expect to see that in the future for sure.
Thank you.
You're welcome.
There was a hand up, I think. It's not. Oh, that's Haiping's gallery.
If we don't have any other questions, let's perhaps move on to our next presenter. Thank you, Joseph, for your excellent presentation. So now may we have Cheuk To for your presentation.
Hi, let me quickly share my slides. Are you able to see my slides?
Let's give it a moment. We are still waiting for the slides to show up.
Oh. It should be there. Is it showing up or?
We're currently seeing the screen of your Teams.
Oh, how about this? Let me try. Is it showing up? Because I pressed the.
You can go to share content. Do you see the button?
I did press that.
Share content. Then you can go to Windows and then select the PowerPoint.
Like that?
Yeah.
Yes.
Awesome.
Okay. Now can you full screen the slideshow so it'll be easier for you? Okay, great.
Awesome. Okay. Hi, everyone. My name is Cheuk To Chung, and I'm from the Cardiovascular Analytics Group. It is my honor today to be able to present at the International Society of Electrocardiology Young Community Scientific Meeting. And today I'll be discussing the implications of machine learning algorithms on sudden cardiac death. So the objectives of my presentation is to provide some information on sudden cardiac death, risk stratification methods, and machine learning, and then I'll proceed to discuss the role of 3 machine learning techniques on sudden cardiac death, and then we can end with some key takeaways and limitations. So sudden cardiac death, or SCD, is an unexpected sudden death due to a heart condition that occurs within 1 hour of symptom onset. It is a leading cause of death in many Western countries, and it also affects a lot of young athletes below the age of 35, and especially in the US. And 50% of mortality of all coronary heart disease patients is also attributed to SCD. As of now, there is a lot of research done trying to identify which type of variables or risk factors are present for SCD. So some examples here include a reduced LVEF, an exercise-induced ST segment depression, and prolonged QRS duration have shown to have predictive value of SCD risk. So there are some existing SCD risk stratification methods. For example, the SCD risk stratification exam is composed of the EPS, ECG, image techniques, and also stress tests, but there is also a lot of scoring-based methods such as the SCD index and the ECG risk score. However, the constraints of these methods is that it is extremely challenging trying to include a lot of time-dependent variables, and a lot of these methods can only utilize a small portion of the available data. As of now, there is a large abundance of heterogeneous data, for example, whether that is through physical examination or ECG readings. But what we're struggling with at the moment is trying to decipher which pieces of that information or data is actually useful in predicting SED. And so machine learning precisely takes advantage of this data overload because it is able to interpret complex data, stratify patient diagnoses, and deliver personalized care as well. And especially due to its ability to learn and improve upon data training, it also acts as an effective complementary tool to existing methods. However, there has been very limited investigation of its implications due to the absence of a regulatory framework for its application in clinical settings, and also there's general unfamiliarity with the technology as well. And so the three that I'll be focusing on is commonly seen in cardiovascular medicine, which is random forest, convolutional neural network, and long short-term memory network. So random forest is designed to perform classification or regression tasks. And how this process works really resembles the normal branching structure of a regular tree. So how it starts off is with information starting at the roots, and then the information will diverge further into the branches. And at each branch, it sort of acts as a checkpoint or parameter by asking a true or false question. So as the information further extends along the branches, this will further subcategorize the information into more finer categories. And then as it reaches the very end, it will be classified into the purest subgroup possible. And then these results are then compared with other trees using different samples. And then what we end up with is a final classification that is based on the largest sum of votes. But in the case of regression tasks, this will be taking the weighted votes into consideration. And so a benefit of this method is that it is able to reduce individual variability, it's more robust, and it's also effective for large data sets with high dimensionality. So one study was trying to look at the near-term prediction of SED in older hemodialysis patients. And what they did was that they trained these random forest algorithms using the electronic health records. And they were trying to see if there was any variables that were predictive of SED within a time horizon. So for example, in this table, you can see that within the 30-day time range after the hemodialysis session, they found that factors such as the albumin presystolic BP and also the creatinine was shown to be predictive of SED. And convolutional neural network is designed to detect patterns and classify images using filters. And depending on the filter being used, it really can detect a wide variety of patterns, anything ranging from geometric shapes to human anatomy. And we commonly see this in medical imaging for brain tumors as well. And so this process begins with receiving a visual input, so let's say a picture, and then this is a feature detector is placed on top of it, and then it is scanned alongside. Now, a feature detector is essentially a matrix of all the variables that we want to measure. And so the calculations we're trying to do is essentially trying to match the pixels on the image to see if there's any local correlations with the variables that is present on the matrix. And so what we end up with is producing something called a feature map. And then when multiple feature maps join together, ultimately we produce something called a fully connected final layer. And then this will help us to generate a list of feature values and votes for a specific category. So one study was trying to look at the prediction of sudden cardiac death, and they used ECG readings from patients who had heart conditions. And so first, that information is placed inside a reoccurrence complex network, and this is to help extract the low-level features in the ECG. And then this is the input that is placed inside the CNN in order to extract some higher-level features. And what they found with this method is that the average success rate was over 94.7%, and that it also helped to reduce the data processing time by 12.19 milliseconds. So the last type is called long short-term memory network. It is designed to learn long-term dependencies and make predictions. And essentially, it allows information that is trained to be maintained for a very long period of time. And it is also a specialized type of recurrent neural network. And how this process works really resembles the conveyor belts that we often see in airports trying to transport our luggages. But instead of our luggages, we happen to work with something like a sequence of words. And these words are converted into vectors. And then these vectors are transferred along a pathway onto the adjacent cell states. And so as this process happens, there is an accumulation of the previously learned information. And then that information goes through a series of complex calculations. And then what we end up with is the production of practical data and a series of predictions as well. So one study was trying to develop 3 artificial neural networks in order to predict cardiac arrest in emergency departments. And they used over 80,000 electronic health records in the emergency department from Korea in order to train the model. And one of them was actually the LSTM. And so this LSTM model is designed to incorporate up to 12 medical updates within a 6-hour time range. So what this means is that each time there's a new measurement that comes up, let's say they change in vital signs or a change in consciousness. And then this update is added into the model in order to make a prediction that is useful. And what they found was that this model actually performs significantly better compared to non-neural network models or methods, such as the modified early warning score. And what they found that was even more interesting was that the hybrid method and combining both the neural network and the scoring system performed actually the best out of all of the options. And so based on some of the evidence that we've seen, we can understand that machine learning approaches really work cohesively together most of the time by leveraging a multi-layered structure entity in order to maximize its utility. It is also designed to be highly compatible with various data types. So some researchers, they might develop a random forest algorithm using lab results and vital signs in order to predict cardiac arrest, while some researchers might use data on heart rate variability or nonlinear features in order to train a support vector machine classifier. And so with this knowledge, we are able to predict SED much earlier on and with much more precision, which I believe is of paramount importance in clinical cardiology, especially due to the nature of SED happening so abruptly. I believe timing is really the key in order to deal with this issue. So with our knowledge in machine learning, this could help us to navigate current preventive measures. For example, medications like beta blockers or ICD therapy or certain types of procedures. Or alternatively, it could also help us with some new interventions. For example, a athlete pre-participation screening if they're shown to be a risk, or a general reevaluation of assessment guidelines, or ICU alarm systems, or inpatient monitoring systems as well. And so in the long term, this could help to reduce the burden of SED on the healthcare system and also the general population as well. However, some limitations do have to be noted. First, an enormous amount of data sets, resources, and time is required to train these algorithms. So this might not be something that is highly accessible worldwide as well. And there's still, unfortunately, the challenge to try to include a lot of time-dependent outcomes, for example, heart failure exacerbations. And so this could lead to data imbalance issues and raise a lot of uncertainty about the model validity as well. And lastly, there's also a lot of controversy surrounding the data confidentiality, cybersecurity, and also surveillance, whenever that is during training of these models or during the actual application of these algorithms as well. And so I believe these factors do have to be taken into consideration when we're developing a regulatory framework. And so my take-home messages are that SED remains a prevalent cause of death worldwide, and by combining individual and hybrid machine learning approaches, this could help us in the prevention and ultimately management of patients at risk of SED, and that further research is necessary to develop a regulatory framework for the implementation of machine learning for the risk stratification of sudden cardiac death. These are my references, and thank you so much.
Thank you, Cheuk To, for your presentation. To get the discussion rolling, I'd like to ask, what do you think about the common criticism about machine learning, the application of medical studies where there may be a lack of clinical justification in terms of the predictors that were found?
I believe that issue might relate to the black box concern that we often have of these algorithms, because essentially the struggle is that we are able to develop these algorithms, and they can do certain predictions and deduce certain results. But the issue is that we combine so many of these predictors and variables together, and maybe that could go up to hundreds or even thousands of variables. But the problem is, we have the result, we have the start, but we don't know what happens in the middle. We don't know if we have factors A, B, C, D, E. We don't know whether it's D that's useful, or A that's useful, or E that's useful. So even if we know the results, it does raise a bit of concern of whether we can actually trust that algorithm, or whether there's any issues when we're trying to verify if those results are correct. So I think that is a common criticism, or that could be an issue when trying to convince people to actually put it into clinical use. I think that would be an issue.
Thank you. Can we have Hai Ping, which I see your hands are up?
Thank you, Cheuk To, for your presentation. So I have a question on the CNN algorithm. So on the slides, you have shown that you will segment the ECG signals into different parts. So did you do any normalization on the segment during the segmentation?
I'm so sorry, I didn't quite get it. There was a bit of a Wi-Fi lag. Could you repeat the question, please?
Sure. So on your slides, you mentioned you did the segmentation of ECG signals, right, into different cardiac cycles, I believe. Is that true?
Not. It's more so that the ECG readings are going through a series of complex calculations, and it is not just entering the machine learning model itself. So let's say in the second example that I provided, it goes through the reoccurrence complex network and the CNN as well. So it actually goes through a series of stages before it even reaches the machine learning algorithm.
Yes. So I see the segmentation is not based on each cardiac cycle, right?
It's not necessarily based on one cardiac cycle. It kind of takes the whole segment of the ECG reading as well. However, to actually understand like which parts of the ECG diagram is being used, I think that is going through very complicated steps of calculations, and that is best understood by experts in the coding field and also the people that actually design the algorithms. So it's extremely complicated calculations for that part.
Oh, I see. I see. Thank you so much.
No worries.
Okay, thank you, Cheuk To, for your answers. So can we have Andony Arrieula, our next presenter?
Yes, can you hear me?
Thank you.
All right. So I will share my screen. Okay. Okay. Can you see my screen?
Yes.
Yes.
Thank you.
All right. All right. Thank you. So hello everyone. I am Andony Arrieula. I am a PhD student in the Lewick Institute in Bordeaux, and I represent you a part of my work, a machine learning technique based on simulated data for pre-procedural localization of ventricular ectopies. So, as you know, to cure the ventricular ectopies, clinicians often use the radiofrequency catheter ablation to cure idiopathic PVCs. And the main problem with this technique is during in the catheterization lab, PVC cannot occur, so it's difficult to for the clinician to localize efficiently the origin of the PVC. So I propose a machine learning technique to predict the origin of the PVCs before the intervention in the lab, using only the cardiac imaging and the 12-lead ECG. So since I talk about machine learning technique, we need a database to train our model. So we perform simulations using the Borovac 5 software, using 17 realistic heart torso models that come from the Bordeaux hospital. For each of these model, we simulated around 500 plus bits to simulate PVC. For each of that simulation, we use the monodomal reaction diffusion model, the Tentoshire Noble Parfoloff ionic model, and meshes that have 200 micrometers edge length. And to simulate the 12 ECG on the torso, we use the lead field method. Then, for each model, a biventricular mesh is created using computed tomography, and all meshes then were registered to reference one using the iterative closest point method. That is an automatic method to register different meshes. And then, using this method, we have all the pacing sites for all the models that are set on the same geometry, on the same referential. And then for each simulated base bit, we extracted first 7 features from the QRS complexes corresponding to the PVC, as proposed by Sophie Giffard. So for each base bit, we extracted first the integral of the QRS, the absolute potential, the timing, and the sign of the global extremum, the number of times the signal cross zero, the number of local extrema, and the sign of the first extremum. And from that, we add 5 features for each base bit. So first, we take the integral and the timing of the global extremum, and we divided by the duration of the QRS. We also took the integral and the potential of the global extremum, and we multiply by the scale effector of the registration. What I want to mean by the scale effector is since all the meshes have not the same volume, it can be necessary to stretch the mesh to correspond to the same volume of the reference one. So the scale factor is simply the strength of the stretch of the registration, and we also take the integral and divided it by the duration and by the duration of the QRS and multiply it by the scaling factor. So for each base bit, we have 12 features, 12 features per lead. And then we'll try to learn the relation between the origin in the heart and these features that we collect on the 12 ECG. And to do that, we use the gradient boosting machine learning method from the Scikit-learn Python package. And to tune the API parameters of the machine learning technique, we use the leave one work out cross validation method that consists in our case, we have 17 models. So we train the algorithm on 16 models, and we test it on the remaining one, and we do that for all the 17 models. So we evaluate the method 17 times, 20 times. That's all. Here a presentation of the clinical workflow that how the algorithm can help the clinicians in the hospital. So the CT scan of the heart is performed, and then we can segment it in a biventricular mesh. And in the same time, we perform the registration, the recording of the PVC to ECG, and then we give that to our machine learning technique, and it is able to make predictions in the pre-real, because we can have a different morphology of PVC, so the algorithm can predict all of the different location depending on the morphology. And then for now, to evaluate the method, we performed a retrospective study. So far we have 5 patients from the Bordeaux hospital. Each of these patients have healthy ventricles. The signals and the meshes and the EP meshes are from the Carto electrophysiological software. Registration of EP meshes on the segmented meshes are performed manually, and the validation of the method was performed on PaceBeat during the EP procedure, and the curious of interest are selected manually and validated by clinicians from the Bordeaux hospital. And here there are the results of the machine learning method for each of each of the 5 patients. You see the prediction error, the Euclidean localization error between the prediction of the algorithm and the real coordinates of the base bit. And we see for patient 1, 4, and 5 we are in between 20 and 30 millimeter of error, and for patient 2 and 3 we are around 10 or 15 millimeter of error. That is reasonable to start efficiently a catheter ablation procedure. But for patient 1, 4, and 5, the errors are too big to be efficient for the clinicians on the EP lab. So we'll try to continue to add patients, add the clinical patients to validate or know the method, and we'll try also to continue to improve the accuracy of the method by giving, for example, more features, or given more models in our training data set to train more efficiently the machine learning method. And thank you for your attention.
Thank you, Anthony, for your presentation. So
Yeah.
I would like to ask, you mentioned that the 5 patients that you've looked at all had healthy ventricles. So do you think the technique could be applied to deceased ventricles, or is there any existing studies that apply this sort of machine learning methods to the mapping of deceased ventricles as well?
So for my method, I think in ventricles that are with a prior infarct is not possible, because the signal will see the infarct in the heart. So the method, I think, will not work. Or maybe if we try to simulate in our database some models with heart disease, maybe it can be efficient. And I don't know if methods already exist. To be honest, I don't know if it exists. I don't know.
Thank you. No worries. May we have Dr. Osman? Noticed your hand is up.
Hi, Andony. Thank you for your very nice presentation. And I want to ask you, in your algorithm, you only understand outflow track PVCs, left ventricle or right ventricle, or do you understand the other part of the left ventricle or epicardial side of the PVCs?
I missed some part of the question because the connection not good.
Okay, I repeat. Sure, I repeat. In your algorithm, can you only understand the outflow track PVCs outflow track origin PVCs, or you can find the other part of the left ventricle or epicardial side of the PVCs?
Thank you for the question. For the advantage of this algorithm is I can predict the algorithm can predict location on all the ventricles. But to rebound to your question, the algorithm, it's more difficult for the algorithm to detect origin in the right ventricle outflow tract. It's more difficult, and we see. I don't know if you remember the first patient who has an error like 30 millimeters. All the pacing sites are located in the right ventricular outflow tract. So so for the algorithm, it's more difficult to detect that, and we will try to improve it because it's the region of interest for the clinicians.
Thank you very much. Yeah, thank you very much.
Thank you. Now, can we have Hai Peng?
Hi. Thank you, Dr. Andony, for your presentation. So I have a question about your mesh. So is your mesh curvature dependent, and did you perform any refinements or quality check on the mesh?
I don't know if I understand the question. You asked for the if the precision of the mesh is important on the registration.
Because I also did some meshing works, but my focus was simulation, the CFD or FEM simulation. So in the simulation, the quality of mesh plays an important role. So I'm wondering if you did some refinement or quality check of your mesh.
I don't do that because the software was developed by my PhD supervisor for 20 years. And he said to me, meshes of 200 micrometers are quite often are nice to make this kind of simulation. So I'm confident about that.
I understand. Thank you.
Thank you.
Thank you. So can we invite our final candidate, Ewa Tomicka?
Yes. Please let me upload the presentation. Sorry. Okay, can you see the slides?
I think it's loading. We're still seeing a blank screen.
Okay.
There we are.
Yes, it is.
Yes, it's working. Thank you.
Okay. So good afternoon, everybody. I'm Ewa Tomicka. I'm a fourth-year student, and I'm representing Student Scientific Association in Department of Internal Medicine and Cardiology of Medical University of Warsaw. And I would like to present to you our study in which we assessed the incidence of fragmented QRS complexes in patients with systemic sclerosis and systemic lupus erythematosus. So to start, there is a group of diseases which are called connective tissue diseases, and their etiology isn't fully understood, but it is postulated that it is mostly due to the autoimmunological cause. And in these diseases, the fibrosis in internal organs occurs, heart, of course, including. And it can manifest clinically as new morbidities such as arrhythmias or conduction disturbances, or even cause a death in patients. So the two diseases that we were focusing on was systemic sclerosis, or SSC, and systemic lupus erythematosus, or SLE for short. In systemic sclerosis, due to the damage to the small vessels and capillaries, the fibrosis occurs, and it can be seen in skin as a hardening and patches, and it also can involve internal organs and even joints, and it can present as a sclerodactyly like in this picture. In systemic lupus erythematosus, however, there is an accumulation of antibody complexes in tissues, and it is causing damage, and it can be seen as a nephropathy or changes in central nervous system. And the most common feature of this disease is the butterfly or malar rash seen on the face, like in this second picture. So what is fragmented QRS complex? It is a new electrocardiographic parameter, and it is presented as a notching in R or S waves, or even additional R waves. It is present in about 5% of healthy subjects, but it can also indicate that there is a scar or damage to the heart muscle, or even some conduction system disturbances. And it is possible that FQRS, fragmented QRS complexes, for short are FQRS, can be used as a potential marker of asymptomatic heart involvement in the previously mentioned diseases. So here are some examples of QRS complexes, and as we can see, we can have notched RS and R waves, additional R waves, or a combination of those. Of course, the FQRS complex must appear in the two corresponding leads at least. In our study, we examined the ECGs of each patient manually, and we did it according to the worldwide accepted DAS criteria. We also measured the disease or severity of those diseases according to the Rodnan score for SSC and according to the SLICC-ACR-DI score for SLE. Also, our patients had an echocardiography examination performed to assess if there are any other heart conditions that might influence our data. In our study, we had 74 patients with SSC and 77 patients with SLE. The majority of in both groups were women, of course, and it is a common pattern in autoimmune diseases. The age and the duration of disease was quite similar in both groups. And if it comes to disease severities, the median score in SSC group was 5 points in 51 maximal points. And for the SLE group, it was 4 points in 49 maximal points. So we can say that the disease severity wasn't, the patients weren't that much affected. Yes, and in our results, we find out that the mean left ventricle ejection fraction was quite similar. I mean, the value of the ejection fraction was quite similar in both groups, and it was within normal range. The same when was presented when it comes to mean tricuspid regurgitation pressure gradient. However, it was slightly higher in the SSC group. SLE group, however, presented more hypertension incidence, and this group also presented a prolonged QT interval, but it was still within normal range. When it comes to FQRS complexes, it occurred in 34 patients with SSC and 29 patients with SLE. So this is much more higher than in healthy population. Also, we find out that the notched S waves were significantly more frequent in the SSC group. However, other patterns occur with similar frequency in both groups. In conclusion, we can say that although the pathomechanism of the FQRS complexes are different in SSC and SLE, the incidence is quite similar, and it is much more it is higher than in healthy subjects. And it is possible that FQRS may be considered as an additional marker of heart involvement in both of these diseases, but it is still quite new, and there is a need for more research in this area. For your attention.
Thank you, Ewa. So I have a question for you. I'd like to ask, since you are saying that the presence of fragmented QRS interval may reflect for more cardiac involvement, did your study, or do you know of any existing studies that looked at the application of fragmented QRS in terms of looking at cardiac outcomes, whether or not it is MACE or whether or not it is ventricular tachyarrhythmias, etc.?
Yes, so it was commonly used in assessing the if the PCI procedures were after they were applied to see if the patients had any they feel better and they have more improvements, but there is still too little studies to say that it is well established, and still it must be more done in this area.
And was it explored in patients with connective tissue diseases at all?
I think not, because it was also only mentioned in the literature that it can occur, but then no one wasn't really doing that study because it's really hard to find that many patients. My clinic actually works with the Rheumatology Institute in Poland, and that's why we had so many people to examine.
Okay, thank you. Now, can we have Dr. Osman?
You're muted, sir, so I can hear you.
Well, I see his hand is up, so...
Sorry, okay, yeah. Okay,
sorry.
Okay. Thank you, Ewa, for your presentation. I want to ask, in your opinion, could MRI be done to identify fibrosis in this patients group of patients? Because we know fibrosis in the lupus or sarcoidosis is a we can identify and we can find with MRI. So, what's your opinion?
Okay, so actually we did another study in which we wanted to see if there is any corresponding images in the MRI, and we're still working on the data. But we've seen that when the patient had, for example, FQRS complexes from inferior leads, there was a change in inferior segments of heart in MRI. So it is quite interesting thing to examine, but we have to work on it more to later show you. But I can say that the hearts are fibrotic hearts in those diseases are quite, I can say, pretty looking, because they have the stripes, and it is even said that they look like tiger heart because of the stripes.
Thank you very much.
Thank you.
I think we are coming to an end of the session. Gary, would you like to do the closing?
Yes, sure. So thank you very much to all of the speakers for the excellent presentations. So congratulations to you all for making the finalists for the oral presentation. So before we finish the session, can you all turn on your camera so that we can have a group photo? And we're going to sum up all the scores and give you a result by the end of the day. We'll email you as well to see who's the winner. So thank you very much for joining. There is also a second session that's just started. So after this meeting, please exit this and then use the other meeting links to join the relevant session. Thank you.
Thank you.
All right. Thanks so much for your effort. So everybody's abstracts will be published in the Journal of Electrocardiology. So we're going to do some editing and send it to you for review before we do that. All right. Thank you.
Thank you, everyone, for attending.
Thank you. Cheers.
Thank you. Bye.
Bye.
Thank you, Sharon.